but it is my absolute pleasure to introduce Dr. Diana Cejas, who is an associate professor of neurology at the University of North Carolina at Chapel Hill and a faculty of the Carolina Institute for Developmental Disabilities. Her clinical work, research, and advocacy focus upon the understanding of effects of ableism on health and improving care delivery and outcomes for children and young adults with neurodevelopmental disabilities. Dr. Cejas has also devoted much of her career to patient advocacy and improving communication between healthcare providers and the disability community, particularly young disabled patients of color. Dr. Cejas shares her own story and other commentary on disability and health via essays and other nonfiction. Her literary work has appeared on high-impact medical journals, prestigious literary magazines, anthologies, and popular media. So without further ado, Dr. Diana Cejas.
So, hello. Hopefully everybody's seeing my screen okay. As you heard, my name is Diana Cejas. My pronouns are she, her, hers. I'm a Black woman whose hair is in long mini twists. I'm wearing a kind of a teal shirt and sitting in front of a bookcase that is full of books. And if you see me looking off to the side, that's because I have some very rambunctious kittens who keep trying to get in the screen and get into the room no matter how often I try to get them out. But as you heard, I'm a child neurologist at UNC. And so much of what I do focuses on really trying to improve the quality of care that we provide to young disabled people, particularly those with intellectual and developmental disabilities. Disability, particularly related to equity, justice, and inclusion related to disability, are all very important to me, both personally and professionally. Just some backstory about me. I am a physician who has neurological disabilities that I acquired while I was in residency. I'm a cancer survivor and a stroke survivor, a neuroendocrine cancer survivor and stroke survivor. So again, this is personal, it's professional. So I'd love to be able to talk about things like this with my colleagues, particularly to get to spend some time talking about issues that are affecting the disability community broadly and issues that are really important to our patients and our colleagues, like neurodiversity. So we're going to talk about that today. I have a couple of objectives. Hopefully, by the end of this talk, you're going to be able to at least describe what neurodiversity is and describe some basic principles for anti-ableist and neurodiversity affirming practice. I always like to start these kinds of talks with a little note about language. On the slide, you will see different kinds of words and euphemisms for disability that are depicted in different colors. Excuse me. You'll see disability, disabled, special needs, physically challenged, diffability, and then other kinds of euphemisms that you'll see here, and again, depicted in shades of purple, pink, and blue. The word cloud itself shows a few of the terms that I use when I talk about disability, more than a few that I don't, and some that are just insulting. And I and other disabled people often prefer to use a kind of identity first language rather than person first language. So if you're not sure what that means, you can think about it like this. If I'm describing myself, a cancer survivor, a stroke survivor, someone who identifies with the word disability, I'm going to describe myself using identity first language by saying, I am disabled, I am a cancer survivor, I am a stroke survivor. For my patients who are autistic, they might say that they are autistic. For my patients who are deaf or hard of hearing, they might say this is a deaf person, this is a hard of hearing person. If I'm going to describe myself using a person first language, on the other hand, I'm going to say that I'm a person with a disability. I'm going to say that my patient is a person with autism or a person with deafness. Really, there's a lot of debate about which is the best to use. And sometimes certain guidelines that we'll have to stick to for journal articles and what have you will say that you have to use this kind of language versus this kind of language. When it comes to talking to patients and colleagues, really the best thing to do if you aren't sure is just ask them what they prefer. But you'll hear me using more identity first language in this particular talk. Some of the terms that I'm not going to be using are handicapped because that's outdated, special needs because disabled people's needs are just needs, differently abled because you can just say disabled, physically challenged, and these other euphemisms for disability. I'm also going to spend a little time talking about ableist terms that we unfortunately use in medicine, but I'm not going to use them other than to point them out and give you some examples of things that we could switch them for instead. But if you'd like some resources on ableist terms and what you can use instead, I'd be happy to share a few resources. So again, I always like to start with terminology since there's so many different ways that we can describe this. First, on this slide, you'll see a little example of a cartoon where you see two doctors looking at each other, and one doctor is pointing back at a bunch of patients and saying, "What do you think they want?" And one patient is saying to make or thinking to make my own decisions. Another is thinking to be asked. Another who seems like he has or they have on sunglasses and maybe use a mobility aid or a cane, is thinking information that I can access. And there's another person who's a wheelchair user who is thinking to be treated with respect. So the definitions that we're going to talk about. First, disability. Well, what is it? There are lots of different ways to define and describe disability, and we're going to talk about a couple of them today, but one that you can really probably are familiar with is something that says that disability is a physical or mental impairment that substantially limits one or more major life activity. So I want you to think about how you personally would define disability and picture what a disabled person looks like in your mind. So, do you tend to think about people with neurological conditions and do you define those people as disabled? And if you do, does it matter what condition they have or their level of functioning, as it were? Does it matter whether or not they're able to be employed? Does it matter, whether or not they identify as having a disability? Well, a description that I particularly relate to says that disability, quote, results from the interaction between individuals with a health condition, with the personal and environmental factors, including negative attitudes, inaccessible transportation and public buildings, and limited social support. So it's not just looking at the medical condition itself as being the thing that is disabling. It's also looking at the societal factors that surround that health condition, the stigma, the barriers, what have you, and look at all of that to kind of figure out what disability is and what it actually means to the person and society as a whole. And unless I'm mentioning otherwise, that's the definition that I'm going to be using as we're going through the rest of this talk. Ableism is, to put it simply, discrimination against disabled people. You can think about it the same way that you might think about racism, sexism, or any other forms of discrimination. To quote Fiona Campbell, a renowned disability scholar, it's a network of beliefs, processes, and practices that produce a particular kind of self and body, which is seen as the corporal standard, and that's projected as the perfect species-typical human. So people who are disabled are cast in a diminished state of being human. When they tend to think about ableism, if people think about ableism at all, people think of prejudice, antagonism, and forms of interpersonal ableism. But it's so much more than that. I mean, again, think about it like racism, think about it like sexism, think about it in like any other form of discrimination with which you might be more consciously familiar. It can be institutional, it can be structural, it can be systemic, because society presumes that everybody is able-bodied, quote unquote, and that negatively affects disabled people. And systemic ableism, which is going to influence a lot of what we're talking about today, is a system of institutions, policies, and societal values that disadvantage people based upon other values like intelligence, physical ability, and mental abilities. I want you to kind of, again, do a couple of exercises with me as we're going through the rest of this talk. And think about the clinic or spaces in which you practice. Is your equipment, like the examination table, gurneys, whatever it is that you use, is that something that's going to be accessible to your patients who have mobility issues or who use wheelchairs? Or, let's say you're in that same clinical space, excuse me, and you're working with someone who has maybe some sensory sensitivities. Is that going to be a space where they're going to be able to interact with the equipment without being triggered in some way or having some issues due to the fact that maybe the lights are fluorescent or there are loud noises outside? Or let's say you want to go out after clinic, everybody does, and let's say you go to a restaurant with someone who is blind or visually impaired. Would they be able to access that menu? All of these things might seem little, but all of those things, the menu design, the clinic design, the spaces that are involved, the equipment and the way that it's made, all of those little things are have resulted from a series of decisions about policy. And those series of decisions were all informed by ableism and can just show how all these things that seem very little all come together to disadvantage people with disabilities. So medical ableism is something that we're very familiar with, even if we're not aware of it. Too often we physicians see people with disabilities as just problems that need to be fixed. We don't necessarily see them in their personhood. And that idea that you can be normal and happy and healthy and disabled is a really foreign idea to us. And sometimes that translates to the kind of care that we provide. So the point of this talk, though, is that we're going to be talking about neurodiversity. So what's that? Well, this term itself has gotten increasingly familiar or increasingly popular in recent years. And that's mostly due to the work of disabled and particularly autistic self-advocates. It suggests that autism and other kinds of neurodevelopmental disabilities aren't pathological necessarily. They just represent differences in the myriad ways that the human brain can develop or change over time. So, who falls under that umbrella? Well, it really depends on who you ask, and we'll talk about that in just a moment. And where did the definition come from? Well, that builds upon the social model of disability. So, on the slide here, you'll see a little diagram that shows that's labeled the medical model of disability. In the center of this diagram, it says this is the problem is the person with a disability. And you see these little circles around that person, all pointing inwards. The person is housebound. They're confined to a wheelchair. They can't walk. They can't get up steps. They can't see or hear. They're sick and they're looking for a cure. They have fits or they need help and caregivers. All of these are problems because of the person who has a disability. We physicians are probably more familiar with this medicalized model of disability. And if we're looking at it through that lens, then we're going to see it as something that results from the person's physical or mental impairments, and we focus on just fixing or curing the impairment to make the person normal or able-bodied or whatever term you would like to use. Some disabled people really don't like this model because they don't necessarily always see their disability as the thing that limits them. And alternatively, for patients with conditions that can't be cured, it might lead us physicians to offer treatments that just aren't useful. Um, so we might be thinking about, again, my patients tend to be patients who are autistic or have other neurodevelopmental disabilities. And in the vast case, for the vast amounts of my patients, the idea of curing their autism, for some of them, it is something that they are interested in. But for the vast majority of them, the idea of being cured is at best distasteful and at worst eugenicist, because so many of them see their autism as a key part of who they are. And in this medical model, there really is no recognition about how societal factors can lead to disability or worsen disability, injury. There's also no recognition of how disability itself can be part of someone's identity. On this slide here, you'll see a different depiction with, again, a person in the center that says the problem is the disabling world. And you also see little things depicted around that circle with the person in the middle, the person who is disabled in the middle. And that includes badly designed buildings, stairs, not ramps, no lifts, special schools, few sign language interpreters, discrimination, inaccessible transport, no parking places, isolated families, poor job prospects. All of those things out in the world are what is disabling the person in the middle. And again, like I said, there's always this debate about the language you use. There's also debate about the kinds of social and social versus medical versus identity-focused models of disability. But we're going to focus on these two just for today. And we'll just kind of say that rather than using the medical model of disability, a lot of disabled people prefer to use the social model instead. And if we're using that lens, then we can see that disability occurs when society and the person's environment don't accommodate their needs, not necessarily because of their medical condition itself. If you make the environment more accessible and make society more inclusive and accepting of people with these kinds of disabilities, then that allows us disabled people to have the same kinds of opportunities as non-disabled people. And in a way, it kind of remedies the disability itself, even if it's not necessarily curing or fixing the medical condition. Under this model, the social model of disability, disability itself is not a mistake of society, but it's an element of its diversity. The social model itself recognizes the role of society in creating and worsening disability, illness, and injury, and it also recognizes that disability itself can be part of one's identity. So neurodiversity, again, who's falling under this umbrella? On this slide here, you'll see a depiction of an infinity sign with lots of little circles that make up the infinity sign. It's the infinity sign of neurodiversity, so it's in rainbow colors. And you'll see different kinds of terms that are on this particular infinity sign that kind of some people think fall under the neurodiversity umbrella. And there's certainly, again, a lot of debate about which people, which conditions kind of fall under this umbrella, but this is one example that one person kind of came up with. And you can see here some of the terms include things like anxiety, bipolar disorder, autism, oppositional defiant disorder, ADHD, Down syndrome, dyslexia, epilepsy, depression. And there are some on here that I'm sure that you're sitting and looking at and you're like, oh yeah, absolutely. That sounds like neurodiversity. Although sometimes people might argue about whether epilepsy is a neurodiverse condition. There are some things on here like not sure what they mean by cultural diversity. That's interesting. When I look at that, I'm not sure what kind of feeling that I have, but I'm sure that the person that put this together had their own thoughts as to why that falls under the neurodiversity umbrella. Same thing with gifted. There's trauma, there's developmental disability, sensory integration disorder. So again, you can see lots of examples of how one person who made this particular graphic decided to label the neurodiversity world. But you might see other definitions with other conditions, other terms, although that some are pretty consistent across the board, like autism and ADHD. Um, Regardless, one thing that we can take away from this is that we're undoubtedly going to see neurodiverse patients in our clinics, and we're going to work with neurodiverse individuals every day, and that's within the workplace and within our greater world. Going back to disability, because if we're thinking about neurodiversity and what all this means for our patients and for our colleagues, then we have to know the context. We have to understand more about that social context that influences how disabled people, how neurodiverse people are viewed, how we view ourselves, and the issues that kind of come up when we're trying to seek healthcare. So, something that you kind of need to understand again is to realize that a lot of these issues are intersectional. If you don't remember what that term means, you have to think about the fact that Kimberly Crenshaw coined this term intersectionality in 1989. And to understand it, you have to think about it as a framework that we can use to figure out how a person's identities and the advantages or disadvantages that come with those identities affect their experiences. I'm going to use myself as an example quite a bit. I am a Black woman. I'm a Black disabled woman. I am all of those things at once. And you cannot pick apart my disability from the fact that I'm a woman, from the fact that I'm Black. You can't take those things apart. So that means that I experience the disadvantages that come with each of those identities in a way that's unique to a person that has that combination of identities. So I, as a Black person, experience racism. I, as a disabled person, experience ableism. I, as a woman, experience sexism. But I'm a Black disabled woman, which means that I experience ableism in a way that is unique to being a Black disabled woman, or sexism in a way that is unique to being a Black disabled woman, or racism in a way that's unique to being all of those things. All of those things are intrinsically linked. And we have to keep that in mind as we're thinking again about how our patients, our neurodiverse patients and colleagues are navigating the world. Um, just a little bit more background information is that minoritized race, poverty, and disability track together. I'm primarily working with kids, so the data that you'll see here is about children, but you can also kind of extrapolate this to think that it's very similar kinds of data for adults as well. And you can see on this slide, it says that 23.8% of disabled children live in poverty, 43.4% of Black disabled children live in poverty, and you can see that discrepancy there. And there are a large population of disabled children that live in poorer and more rural states. So you think about all these things as we continue to think about issues with access to care. When it comes to being in healthcare and disability in healthcare, to paraphrase one of my professors from med school, being disabled is bad for your health. And that's true for kids and adults. Disabled people are more likely to report that their health is poor, more likely to have multiple chronic illnesses. They're at higher risk for unintentional injury. They're more likely to be the victims of physical and sexual assault than their non-disabled peers. And they're less likely to receive preventative care, more likely to use emergency services, more likely to be uninsured or underinsured, and they're more likely to skip or delay care because of the cost for kids and adults. On this slide here, you'll see another little infographic that says better health for people with disabilities. This was designed by the World Health Organization, and you can see a figure that looks like they're holding either a mobility device, excuse me, and it says that people with disabilities have the same general healthcare needs as others, but they're two times more likely to find healthcare providers' skills and facilities inadequate, 3 times more likely to be denied healthcare, and 4 times more likely to be treated badly in the healthcare system. Some of the barriers to care that disabled people face when they're trying to enter into the healthcare system include these physical barriers like inaccessible scales, medical tables, things of that nature. Non-inclusive programs. Sometimes the example that I'll give is thinking about someone who might have a communication kind of a disability, and maybe they're trying to be in a support group. Well, is that person who, let's say, uses ASL, are they going to be able to participate in that support group like everybody else? Or is there going to be a communication barrier, another very common barrier, that's going to prevent them from being able to participate in that program? Limited access to transportation. Accessible transportation can be very, very difficult to find. Relying on public transportation, I'm pretty sure a lot of us, particularly those who work with kids, probably know a lot and could say a lot about Medicaid transportation and how unreliable that could be, or how public transportation can be really unreliable and have our patients that miss appointments or not be able to get to where they need to be because they're relying on this inconsistent kind of transportation. Other societal factors and policy. Again, stigma is something that is very real. Oh, my earring fell off. Stigma is something that is very real, and it is something that affects our patients and colleagues and friends' ability to kind of move about the world. Little to no care coordination. So if you think about, I'm thinking about my patient population, they're coming to see me as their neurologist. They also have a pediatrician. Oftentimes they have physical therapy, occupational therapy, speech therapy, other therapies. They might have 2 or 3 more specialists, and who's doing all that care coordination? That's their caregivers. And sometimes it can be very fragmented, and it's very, very difficult to kind of keep up with everything. Obviously, the more disabled you are, the more higher support needs that you have, the more costly things can be for you. And then, of course, dealing with stigma from healthcare providers, unfortunately, is something that we also have to think about. As an example, certainly we know that there are quality of care issues for disabled people, for kids who have intellectual disabilities who are in the hospital. I took some of this information from a study that showed some of their experiences. Minoritized children in particular, so Black children, Latino children who have these intellectual and developmental disabilities were more likely to receive suboptimal care. So either they had an issue with the quality of care that they were being provided, or they weren't receiving the level of care and weren't getting as quickly as they needed to. These kids also had a higher rate of clinical safety events, whether that is falls, whether that is wrong medication, whether that is some kind of behavioral response or behavioral event. And they're more likely to receive non-standard therapies. Particularly, some of the data that I found was around these kids with syndromic epilepsies and not receiving the kind of standard therapies that they needed when they had LGS or something of that nature. Ableism in healthcare, it's a thing. It's something that we don't necessarily always think of. It's something that we don't like to talk about, like we don't like to talk about discrimination in healthcare in general, because for the most part, I think a lot of us are still coming into this wanting to help people. So we don't want to think about how healthcare can also be harmful at times. But discrimination does affect disabled people's health. And it comes out in lots of different ways. One of those ways is that um, physicians across the board report that they have decreased knowledge, skills, and comfort with disability, particularly when you have people who have higher support needs, particularly when you have intellectual and developmental disabilities thrown on top of everything else. So you might feel absolutely comfortable managing that patient with epilepsy who does not have an intellectual disability. But as soon as that gets thrown in there, and they have maybe some behavioral challenges, or maybe they're non-speaking and they have some really high support needs, that might be when you get to feel a little bit less comfortable. And that's something that's very common. And the patients and their caregivers and families can pick up on that discomfort, and that might lead to a degradation of trust or a change in the relationship between the physician and their patient and the families. And institutional ableism is also something that influences care. So it might mean that oh, these people that are running healthcare systems don't want to spend as much money or don't necessarily want to offer these programs, again, usually because of money and funding kinds of issues. But that's something that can all influence the kind of care that we provide. Um, and this limited knowledge, again, limited knowledge, our as physicians, limited knowledge of how to care for disabled people, what to do when we're trying to interact with disabled people or neurodiverse people, how to understand their needs. All of that really changes the quality of the relationship that we have with our patients. So, for as far as medical ableism is concerned, we don't want to think about it, but we also have to realize that interpersonal ableism and discrimination is also real and it's also happening in our clinics. It's a really Discrimination is a huge part of disabled people's lived experience. And even if they're coming to us fresh, so this is the first time we've met them, we have to think about all of the interactions that they've had with other doctors, other people in the healthcare field, where maybe they weren't being listened to, or maybe, for a person who's a wheelchair user, maybe you were talking to their friend or the person that came with them rather than talking to them directly. Maybe there were things being said like, oh, you should mourn your child after they have gotten a diagnosis of a developmental disability. That's a very common sentiment. Maybe there are other kinds of little indignities that help lead to feelings of dehumanization and feelings of degradation that the person has experienced. And that certainly affects how they see healthcare and healthcare providers. So we've been talking about disability and what it means for our patients, but we also have to look at disabled physicians because whether or not you think we're here, hello, we are definitely here. There are certainly also disabled physicians who have intellectual or developmental disabilities for the most part. And we have to know that disableism doesn't just affect patients, it affects us too. First, we know that discrimination keeps disabled people out of medicine to begin with. I'm thinking about the fact that I work with quite a few disabled and chronically ill pre-meds and med students, and so many of them have the same story about being told, maybe this isn't the right career for you, or maybe you're not going to be able to keep up, or maybe you should consider doing something else. And they're just encouraged by people who think that they're doing the right thing for them to not look into medicine at all, despite the fact that they might be excellent candidates. The numbers that you'll see on the slide, it says that 3.1% of practicing physicians and 4.6% of medical students in the US have a disability. I want you to compare that to the fact that we know that it's about 25% of all adults in the United States are disabled. They have some form of disability. Excuse me. That's 1 in 4 adults. So what is the discrepancy that we're seeing on the slide here? Well, I've been able to talk to some of the authors of the particular paper that this data came from. And part of me still wonders if this is really true because we're only keeping this many people who are disabled in medicine. And I also wonder how many people are out there that don't feel comfortable to disclose their disability to researchers. Because disability and neurodiversity are still heavily stigmatized in medicine. Even if you get in, as soon as you disclose that you have a disability, suddenly everything about you can be called into question, whether or not you're fit to be a doctor, whether or not you should be able to keep up. And then also thinking about the fact that maybe you have some accommodations that you need to be able to put into place. And that might be seen as getting special treatment. You might have people who will actively make fun of you and your disability, or in the case of certain kinds of conditions, you might be subject to really close and intense monitoring. You might be at risk of losing your license. There are all kinds of things that kind of lead people to stay silent about their disabilities, chronic illnesses, and their neurodiversity while they are actively in medical training and practice. And you can imagine that that can lead to some really negative emotions about your own disability and kind of also lead to um, other kinds of negative outcomes that we have, like burnout amongst disabled physicians. So I want to talk very briefly. I know we got started a little late today, but wanted to very briefly talk about identity development and disability identity development so that we can get back to the idea of like what do we do with neurodiverse, like how can we improve our practice around neurodiversity. So I've been talking about disability and ableism, and nothing I said sounded good. but I keep talking about disabled people. I keep using identity first language. I said that I'm disabled. And so it might sound strange to you to hear those two things and recognize that there's lots of stigma around disability, and yet there are still people who want to identify with this term. So, knowing what we know now, we have to understand how a person goes through in this individual process of disability identity development. And this particular model that you'll see, we'll talk about over the next few slides, is one that was put together by Gibson in 2005. The first stage is passive awareness, stage two is realization, and stage three is acceptance. And so during the first stage, the passive awareness stage, really, and this can be true for someone who was born with a disability or acquired it later. At that point, most of the time, these people have no real role model of disability. No one else that they know with their particular conditions that's in their lives or that they are able to see in a positive kind of a light. For the most part, medical needs are being met, but then also people are being kind of taught to deny the social aspects of disability. So, kind of don't look at me, don't pay attention to this. And disability becomes a silent member of the family. Like it's there, but you're not going to ever really acknowledge it. For people that are in this stage, there might be a lot of codependency with their family or their caregivers. There might be a lot of like really wanting to be the good boy or the good girl, and that's true for adults as well, where they're wanting to just show how much we can do and prove it and all those kinds of things. At the same time, you might be shying away from attention because you don't want people to be able to pay attention to you because then they might see your disability. During stage two, this is when you begin to see your own self as having some kind of disability. There might be a lot of self-hate and anger. You might be like, why did this happen to me? There might be lots of feelings. Again, think about all of the things that we talked about that's related to disability, the stigma, the barriers you're facing. And you have to realize that, like, when you come to a point where you start to recognize, oh, hey, I am in this group, it can come with a lot of confusing feelings, and a lot of them are very negative. There might be a lot of concern with how others perceive you as a disabled person. So how you look, how you dress, how you act. For the person who is already in medicine, you might be very concerned with how your colleagues are going to see you as a clinician, given your disability. Concern with your appearance, and then the Superman or Superwoman complex. And I can certainly speak to that because while I was in this process of my disability identity development, I think, I was in residency, and residents sometimes already have a complex where it's like, I've got to be the best, I've got to do the best, I've got to be like, I don't need to sleep, I don't need to eat, and really push themselves in unhealthy ways. I certainly did that when I was in this position myself, and kind of wish I could go back and tell my younger self that it doesn't have to be that way. Um, Before we get to the third stage, I do have to acknowledge that internalized ableism is a thing. Just like internalized racism, internalized sexism, it's something that we all deal with, disabled people included, and something that we have to work through actively. And again, Fiona Campbell in 2009 wrote that this internalized ableism is coming from your distancing yourself from disability, your own or everyone else's, and then doing things that kind of perpetuate ableism. And you'll see that on this little diagram here, where you see that two circles that depict distancing yourself from disability, plus perpetuating ableism leads to internalized ableism. Stage three is what happens when the disabled person accepts their disability. And so, what they might start to do is seek connection from other disabled peers. They might develop community based on these shared experiences or feel included in their community with other disabled people. And there's a shift in their focus from feeling different in a negative light to really embracing themselves. They might start to see themselves as relevant. They're no more than others, they're no less than others. And they might begin to incorporate others who have disabilities into their daily lives. They might start to get more involved in disability activism and advocacy. I know I did. And they really start to integrate themselves into the abled world as their full self, as their disabled self, knowing that even if they do have conditions and things that they would like treatment for or help with, or they need support, that is okay. That is just them, and their disability is part of who they are. So it might sound strange to hear that someone feels positive about their disability, or that they can be disabled and proud, or like the case that you'll see in this picture here, there is a young person who is smiling. They're holding up a sign that says autistic in rainbow colors, and it says autistic and proud. And it looks like they might be standing outside and maybe protesting somewhere. I'm not sure. Um, but if it does sound strange to you to hear someone say that they are autistic and proud, or they're disabled and proud, I'd like you to just kind of think about why it is and why you feel that way. I'd also like you to remember that it's okay. It's normal to be disabled. It's 25% of the population. It's something that's very common. And it's okay to have a positive thought about yourself as a disabled person. It's okay to have a positive identity, your disability identity. It's okay to want to connect with other people, to form community with other disabled people. And not only it's okay, it's also good for your health. Because something that we know is that having this strongly positive disability identity has been associated with outcomes like improved perception of their quality of life, decreased depression, anxiety, and other mental health issues, and other kinds of really positive mental health outcomes. People with positive disability identities are also usually better at advocating for themselves in their in clinical settings and with clinicians, and are better advocates when it comes to trying to access care. On this slide, you'll see a list of certain kinds of principles. Now that we have this better understanding about disability, about ableism, about neurodiversity, we really have to talk a little bit more about these principles about neurodiversity affirming practice. So they're listed here on the slide. And again, I'd love to talk a little bit more about each one, but to kind of put everything all together. The first one, of course, is intersectionality. And that's why I wanted you to think about it a little bit as we were starting this conversation. You have to understand that every person has myriad identities, and you have to take those identities together to understand everything that a person is dealing with and how they move about the world. Second principle is respecting autonomy. So again, thinking about this, particularly for my patients with intellectual disabilities or autism, other kinds of neurodevelopmental disabilities, sometimes we physicians might not want to respect that person's autonomy, but they still have, even if I hate it when people say, oh, I'm going to be this person's voice if they're non-speaking or what have you. That person still has their own wishes, their own goals, their own wants for themselves. That's something that we should be able to take into account when we are working with our patients with neurodiversities of any kind. Validating differences is also something that's important. Everybody's different. No one's going to be the same. And it's perfectly okay. I think one of the things that I end up doing with my patients after a new autism diagnosis is just kind of normalizing things for their parents and their families. I remember one of my patients in particular, who I said something that they were doing was, oh, I was like, oh, yeah, that's totally normal. And the mom just paused for a second because she was like, well, that's weird. No one's ever called my child normal. But what they were doing is something that's expected of a child who is autistic to do. So being able to validate those differences is something that's very important for our families. Presuming competence. Again, sometimes we'll think about things like this from the perspective of a clinician and think, oh, but our patient can't make those decisions, or maybe they have an intellectual disability or what have you. But people can still understand their bodies. I still like to say, they're the expert in your body, and you can help me as a clinician figure out how to help care for you the best. Reframing expectations. So maybe you are coming in with these expectations and someone is going to be able to do X, Y, and Z, but because of their disability, they can't, or it's very difficult for them. Well, maybe we don't need to look at them and have these kinds of expectations. Maybe we need to look at things in a different kind of a way. Promoting self-advocacy is something that we clinicians can definitely get our patients to do. And one of the things that we can do is by doing all the rest of this when we're talking to them, really encouraging them, like say, hey, you have these goals for yourself. You have these things that you want to do with your life. Let's figure out how we can work together to get you to that point. Let's try to figure out what kind of things that we need to do to get your health together to help you be able to get that point so that you feel like you have the language, the tools, the knowledge to be able to advocate for yourself when you're in different clinical kinds of settings. Rejecting neuronormativity. I don't even know what normal is in neurology, and I don't think any of us really do. Um, Neurodiversity is something that is there, it is common, it is real. And so it is definitely something that we need to be, recognizing and not wanting to put everybody into a normative kind of a box. Prioritizing lived experience. Again, we're coming into these settings with lots of clinical training. Maybe we've done research for 20 years. Maybe we have all this clinical expertise, but still we don't know what it is to live in that person's body. We don't have that knowledge of their lived experience. So we need to recognize that that's a kind of expertise as well and acknowledge that. Nurturing a positive self-identity is also something that we can do by normalizing things, by using respectful language, by if they are, on their disability identity journey, trying to provide positive role models and connection with community. Those are all things that we can do. Adapting systems and environments is also something that we clinicians can do. So if you go into that examination room and you're like, hey, this table is inaccessible, figure out who you need to talk to make that comment, to say this is something that your patients need. If you're going to do a talk, you can do things like give visual descriptions of things. You can make sure that captioning is something that's available. You can make sure that it's in person. It's in a room where wheelchair users are going to be able to access that kind of a thing. And kind of going along with that is respecting all forms of communication. And that's regardless of whether it's written, verbal, whether somebody has a language barrier, whether somebody needs to switch between different kinds of communication techniques. All of those things are important. And here is another depiction of neurodiversity affirming practices, including there's a picture of a little brain in multiple colors. Below it, it says embrace differences. Examining your own biases is incredibly important. We all have them. We are all dealing with internalized ableism. We are all dealing with other kinds of internalized forms of discrimination. We have to be willing to look at that and to say, okay, now that we have it, how do I actively fight against it? Who can I learn from? Who's already doing this work? And how can I make this part of my own clinical practice? Prioritizing lived experience, you'll see it looks like two people are sitting next to each other and one person has put their hand on the other person's back. There is another one that says challenging neuronormative bias, and it's under a picture of a one-way sign that's crossed out. There's another picture that says active collaboration, and it looks like two people are planting something together. There's another little picture of two people depicted in different colors that look like they have two different shapes around their brains, a swirl and a little squiggly thing that says validate differences. Promoting self-advocacy, it looks like there's a person standing in a power pose, but they also have somebody flexing behind them. Coming from a strengths-based approach, it's another person who also looks like they're standing in a power pose and flexing. And then raising awareness is depicted under another rainbow sign of neurodiversity. I want to make sure that we have some time for questions. I know we got started a little late, so I'll just show this slide quickly. Excuse me. This is showing some ableist language and what we can do to start unlearning it. Again, it's incredibly common in healthcare. And if you're interested in more resources on how to look at ableist language, how to start taking it out of your own personal lexicon, that's something I'm happy to share. Just to read off a few of these for accessibility, you'll see in one column it says instead of, and the other column it says use. So instead of wheelchair bound or confined to a wheelchair, just say wheelchair user. Instead of saying blind to, you can say ignorant or unaware of. Instead of saying normal or healthy, you can say non-disabled. Instead of saying suffers from, you can say has a disability. So those are just some examples, and I can provide a little bit more information if you would like. Some other things to remember are for just for disabled, you can just say disabled. Just using the word helps take some of the stigma out. You can ask that person about whether or not they would want to use person first versus identity first language. Please, please avoid labels and stereotypes. If you have met one autistic person, you have met one autistic person, and try not to label every single person that you meet the same way and expect them to act the same way and think the same way. Another thing that's very important if you are in the clinical setting and you recognize that one of your colleagues, for example, has or some kind of neurodiversity, Do not out them without their consent. Maybe they felt comfortable telling you that they're autistic, but they don't want other people to know, and that is their business. So don't tell other people without their knowledge and their consent. So, what lastly can we do to foster these positive neurodiversity identities? Well, first, you can recognize the importance of neurodiversity as an identity. Think about that identity development and why it's important. We also have to acknowledge that ableism is something that negatively influences health and why. We need to explore our own biases. We have to challenge them every single day, and it's something that can be done. We can incorporate some of these practices into medical training. So how we teach our trainees and how we also talk to our colleagues for kind of talks like this. We can examine office and institutional practices through an equity-focused kind of a lens, and we can use equity-focused language as well. So on this little slide, you'll see this was designed by CDC. There are 4 individuals. It looks like they all have various genders. There's one person who is a wheelchair user. There's another person who looks like they are blind or visually impaired and they are using a mobility aid. Another person who looks like they are an amputee of some sort and they have a prosthetic. And another person whose disability I'm not able to see. And this says ally. Acknowledge and respect individual experiences and abilities, learn about different disability types, leverage your influence to promote accessibility and inclusion, and yield the floor to people with disabilities to help identify and eliminate barriers. So I know kind of went fast for those last couple slides there, but I wanted to save some time for questions, and I'm just going to stop sharing so that I can see you.
All right, if anyone has any questions, please put them in our chat and I'll go ahead and read them for Dr. Cejas. So please post any questions in the chat and we'll ask them. See that Allison raised her hand. Allison, can you just put your question in the chat, please? And I'm happy to go ahead and read it. Dr. Cejas, one thing that I hadn't realized is just how poorly equipped a lot of offices and healthcare facilities are for treating patients with disabilities. Can you speak a little bit about that?
Yes. Well, I mean, you're absolutely
Sorry,
right.
can I just
Oh,
briefly just put the question in the Q&A section,
okay.
not the chat. Sorry.
Okay. Yes. I mean, you're absolutely right. A lot of our medical buildings are completely inaccessible or accessible, but to the barest standards required to meet ADA regulations. And I'm sorry, my kitten has decided that she wants to play with my legs. So that's what you see going on over here. Um, but I remember, I wish I had taken a picture and it was summed up so nicely. I went to see my own doctor and happened to go to the bathroom, and there was a sign saying, this disabled, basically had a picture of like, the standard disability logo with a no through it saying you must go to the second floor to use the bathroom, and the elevator was broken. How are people who have a mobility issue or need a wheelchair going to get to the second floor to use the bathroom if the elevator is broken? There's just, I think, a lot of the institutions, there isn't necessarily a thought about this kind of design. There aren't disabled people who are at the table when it comes to making decisions. So that's, I think, a time where we can step in and advocate. If you see that your patient, or you notice that you're only able to examine your patient when they're in the wheelchair, ask why. Say, hey, is there something that I can do so that I can get a more accessible kind of a table? If you work with patients with neurodevelopmental disabilities and you notice that they're always having issues because of the light, ask why. Say, hey, is there a way that I can use like a dimmer kind of a light function in here? Is there some other lighting that we can get? Or they're always blowing leaves out behind our office and it's incredibly loud. And sometimes that will also make it so that some of my patients just really have meltdowns. So I'll say, can I be moved to a different room so that they're not as close to the people that are blowing leaves all the time over here? And we can think about different ways that we can make it so that it's a little bit more sensory friendly for these patients. But I think the answer is There's not always going to be disabled people in the room when it comes to decision making for how these clinic spaces are designed, but maybe we might be. So we can start to notice what it is that our patients are needing and try to make that known when it comes time to make these decisions.
Christy, sorry, Allison Christie just wanted to say that it was a fabulous talk and thank you for the
Thank you.
and Mahir Kakara also said amazing talk, Dr. Cejas.
Thank you.
Can you just speak briefly about some of the advocacy work that
Mhm.
you are engaging in to get, people like yourself at the table so that we can design
Mhm.
better spaces for patients with disabilities?
Yeah. So I am lucky enough that I've been involved in advocacy in a couple of different ways. For the most part, particularly because of my own bandwidth as a physician, a lot of my advocacy, at least for the last couple of years, had been kind of limited to digital advocacy. And that means, even though people think it's silly, posting on social media, contacting representatives through letters and letter writing campaigns and things of that nature, and also writing articles. I write quite a bit, so sometimes that means writing opinion pieces for different kinds of avenues. I feel like I'm always talking about the same thing and just in different ways to different audiences. So I might write an article that's talking about the exact same thing, write it for physicians, also write it for the general public because I know not everybody's going to be able to be in both kinds of spaces. Sometimes that leads to opportunities to go and actually talk with policymakers in particular, which is always interesting for me. I don't think I'm political or very good at the political arm of things at all, but it's nice to be able to be in those rooms so that I think that sometimes we physicians forget how much power there is just in the fact that we are physicians. So we can take what our patients are saying in the clinic. I can say, hey, disabled people are saying this, 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 and this. And you might have a policy person who's not necessarily hearing that or understanding it, but I can come into the room and say, hey, this is what my patients are saying. This is what they need. Can you help me figure out how that we can do this together? And also, I've been, again, I keep saying I'm not a policy person, but I keep annoying my professional organizations like AAN to do things like this. Also, American Academy of Pediatrics and the AMA as well to try to see if we can push things forward on disability for AAN, AAP, AMA members. And that comes to includes education. That includes having disabled people as part of the team, not just our patients that we're learning from, but actually learning with to design curricula and things of that nature. And then also to try to see if we can't do something about the technical standards as they relate to disabled residents and medical students. Um, Definitely have a couple more policy kind of things that are going to be coming out and written work that we're working on related to ableism. And I'm excited for y'all to all see it. If you're interested in learning more, I'm happy to talk about that too.
And there are two additional questions. One asks, how do you keep yourself from, or how do physicians keep themselves from falling into paternalistic patterns of behavior towards their patients? And then the other one is any resources that you can point disabled patients to help navigate some of the challenges that they go through outside of the office.
Mhm. Um, Thank you. These are all good questions. I would say, how do I keep myself from falling into like paternalistic patterns? Um, I mean, it's always hard. So I would say just recognize when you're starting to do it. If you have that patient, particularly who is, has a neurodevelopmental disability, intellectual disability, just try to remember, especially for the patients with intellectual disability, I think that paternalism will come out strong. It's like you want to kind of do everything for that person, but that person still has their own thoughts, their own mind, their own goals. And there are ways that you can find that out. You can work with, if they have a caregiver or someone that helps them communicate, you can work that with that person to try to see. If you can't, just remember that this is somebody that you're supposed to be partnering with, not necessarily making all the decisions for. And if you keep that in mind, I think that that's helpful. I think also learning as much about ableism and disability in healthcare is something. Coming to this talk was an excellent start, but also try to put yourself into positions where you're learning from disabled people. And that can be as simple as getting a little bit more active in social media and like seeing what patients are talking about. I remember the first time I started to get more active online in some of these spaces, I was like, wow, disabled people are talking about all of this stuff, and I expected physicians to be talking about it too, but we weren't. So it started having me ask questions about like, why aren't we covering these things the same way when this is clearly something that disabled people are interested in? And sometimes that means you're going to hear conversations where you're going to be like, oh, that's terrible. And it's going to make you feel away. It's going to make you feel threatened as a physician. But you need to just kind of take a minute, step back, sit in your discomfort, and figure out how you can continue to learn and where you can change your practice so that you can start building better bridges with the disability community. When it comes to other ways for disabled people to navigate challenges, sometimes I will work with specific kind of community groups. So trying to build those relationships with community groups of the patient populations that I serve. I know here in North Carolina, we have an incredibly active Autism Society of North Carolina. I know quite a few people that work there, and because I have those relationships with people that are like helping with peer navigation, and a few of the people that work in the clinical programs, and a few of the people that work with some of the educational programs, like I know them and I can tell the patient, hey, this is a good resource for you, go over here. So some of these disability centered groups I think would be excellent. Again, sometimes social media is great. Sometimes it's a little bit of a monster. But if you can find some of those places where you can have that kind of one-on-one relationship, I'm also thinking about it for like our Duke 15 Foundation, the Angelman Syndrome Foundation. Those are patient groups that I work with pretty closely. So I can always feel comfortable sending patients there so that they can find that connection and find resources that might be helpful to them.
All right, two last questions. Are there any resources we can use to train residents and medical students better on ableism?
Mhm.
And any alternative language for things like normative data or normal percentile?
Yes. So residents and medical students better on ableism. There's so many books that are great, but if you want a very basic primer, there's a book, gosh, I always get the title wrong, but it's by Emily Ladau. I want to say that it's Demystifying Disability. It's a very quick read. Um, yeah, it'd be wonderful if I could find it in my library. Let's see, Emily. And Emily herself is delightful. I would also say that there are several books that were written. Actually, this is going to be like a shameless plug. Um, Disability, Visibility. This was by Alice Wong. And actually, I have an essay that's in here too. Alice is a force. She is a disabled self-advocate. She started the Disability Visibility Project and has put together a couple of different anthologies about disability by disabled folks. I highly recommend that. And then there are also,
Just briefly, I'm going to put the name of that, Demystifying Disability, with the author in the
yes,
chat.
yes, thank you so much. And so there are certainly books that you can give. I think it's always wonderful to get this information from disabled people themselves. There are different kinds of curricula that are being put together on ableism, also curricula that are being put together on things like inclusive communication, including, I think I can say that we're working on one for AAN that's going to be out there soon. Um, and yeah, I have a lot of different ones that you can use. You can feel free to email me. I could maybe put my email into the chat too, and I can just send some out to you. And then the other question was,
Other terms you can use instead of saying normative data.
um, well, hmm, normative data. I think for that one, it would kind of depend on how you're using it. Again, um, there is a there is this online collective that's called Rooted in Rights that does a lot around inclusive language and terms that you can use, and they have a nice primer. Also, there is oh, what is Lydia's last name? Lydia Brown, who is a disabled self-advocate who has done a lot on inclusive language and disability. I might look into their work a little bit more because they might have a better idea as to what you could use rather than saying normative data. Um, I think I feel like I have to think about this question a little bit more, but those are two resources that I think that you can think of. And you can look a little bit more into that might give you a little bit more information on different language that you could use.
All right. Well, thank you, Dr. Cejas. This was an amazing talk, and thank you everyone for joining us. We have another webinar coming up in December. I believe it's December 17th at 2 p.m. as well. 2 p.m. Eastern Time, 1 p.m. Central Time. So please join us. But again, thank you, Dr. Cejas. Very enlightening, and you're doing amazing work, which I hope a lot of the people who joined us take on so we can improve how we treat our disabled patients, our patients with disabilities. So thank you. And then anything else, Leah, from your standpoint?
Yes, so our thank you once again, Dr. Cejas, for joining us. And then we also have a webinar on December 5th on LGBTQI plus issues in neurology.
Thanks, everyone.
Please join us, and thank you for joining today. Have a great afternoon.